I'll start off and then we'll let everybody else carry on. We're going to show you some innovative new techniques to manage a dislocated lens. If the capsule is intact and a shift is occurred due to inadequate zonular support, the best way is essentially using some of the newer techniques. But let me show you how it works out. This is what we call the trans-haptic protein technique of a secondary implant. We use a 27 gauge needle, insert it from both sides, put on the needle on both sides, and those of you who were here earlier would have seen something very similar to what I'm showing. Standard method as it has gone on until now. But there is a problem. Sometimes the lens spindles and you are left in the end with the lens running at a horizontal plane rather than lying where you really should. So I thought, and how do we solve that problem? So let me show you how I've solved it. This is what I call as the disc dumbbelling technique. It's a double technique. It's a new technique. To the best of my knowledge, it's not been done anywhere in the world before. At least I couldn't find any reference to it. Or any same way, you feed in your protein into a 27 gauge needle. Feed it out. We use fusion clips. Here we fit in a chamber. single stop of dissolvable vicryl is usually adequate to solve the problem. So this solves the problem which you have had of spindling. So now the lenses will no longer spindle, they will remain stable. So this double dumbbell method, utilizing these two little loops inside, is what works well. You insert a little Vigamox to settle it down, and that is fine. Thank you. Sorry? No, the spindles are used, essentially they're used to support the lens and then needle comes through it. So you give a big space around the side. It is silicone. It is used by plastic surgeons. They call them, you can, but this works easier. And the advantage of this material is pure celestic. It is used, it already is in use by plastic surgeons, so it's nothing which we have to do. And you get it in different thicknesses. This thickness of this loop is 0.5 millimeter. I would have preferred quarter, but I couldn't get it. It's as simple as that. But this seems to work well. Sorry?
Can we use the regular cautery instead of a low heat?
Yes, you can. You just hold it a little further away. No, not that cautery. No, you require a loop cautery. With a heat cautery is required. Thermal. That thing doesn't work. It's freely available at Amazon here. It's one of the cheapest. Yeah. But essentially the whole thing is, if you see, it is essentially the creation of this dumbbell, these two little round pots through which the lens passes, which essentially makes all the difference. Because this is where the key of the whole situation lies. If you can do that, then the problem ends there. Because these attach onto the sides and loop on. So the one problem which I've always had, as I said, is spindling. That spindling problem goes away completely. Please. Amar, could you introduce? Yeah,
so we have with us next is Sri Ganesh. I think.
By the way, let me first mention, Sri Ganesh was the one who first started in India utilizing the dumbbell method. So mine should actually be called as Sri Ganesh's modification of Keiki's technique, or Keiki's modification of Sri Ganesh's technique. But he was the one who brought it in first, which was about, I think, a year before COVID.
Yeah, 2 years.
2 years before COVID, and that's where it is. So I'm only following in his footsteps.
Thank you. Good afternoon, dear friends, and I think to follow on, I'll talk about newer techniques of scleral fixation of IOL, and those are my financial disclosures. So optical rehabilitation in patients with aphakia presents a unique surgical challenge. Choice of IOL material in the presence of little or no capsular support includes antechamber lens, iris fixated IOL, and SF IOLs. So each of these techniques have its own merits and demerits. AC IOL, you can have damage to corneal endothelium and angle structures. Iris fixation, you can have pigment release and inflammation. SFIOL, advantage of a more physiological position near the nodal point of the eye and a greater distance from the cornea. Sutured SFIOL has its problem. You can have suture erosion, breakage. Then you have glued IOLs also, which Dr. Amar, this is his publication. You can have issues like with any other procedure, scleral flap issues, haptic extrusion, etc. Yamane technique also is technically challenging, and you can have IOL decentration tilt, pupillary capture. I've had this. Then the four flange technique was described by Dr. Canabrava in Brazil. And then we did a modification and preloaded the Prolene into the 27 gauge needle, and that's what Dr. Keiki also showed. There's a modified four flange technique. So all you need is calipers, 27 gauge needles, 6-O-Prolene, 2 strips about 5 centimeters long, and you can use a PMMA IOL with eyelets, which is readily available, and you need a Bowie cautery or a, so this is how it is done. That is the proline, 6-O-proline, and you just measure about 5 millimeters. So you pre-thread it into a 27 gauge needle. So this is the modification of the Canabrava 4-flange technique. Rather than trying to railroad it after putting the needle. So once you put it 1.7 millimeters from the limbus, push the proline so that it comes into the eye, it's visible, and with a micro forceps you can just pull it out. And then similar thing is done on the other side, 3 o'clock, 9 o'clock positions. And this is the PMMA lens. So you insert it through the eyelet of the PMMA SF IOL, and you can put it in through this little tunnel, pull it up, and then hold it taut, because if it's loose, again the lens will move. You can have a tilt and a yo-yo. Hold it taut and then cauterize it. And this is, I'll show you some interesting, this was a case which had an injury, aniridia, underwent a corneal graft. The cornea was, again, the corneal graft was failing, so we decided to manage it. There was a regrafting to be done, so I decided to put a aniridia IOL. So I'm using the modified 4-flange technique. Again, pull out the 6-O-proline, and this is the aniridia IOL with 4 mm aperture. So we asked for a 4 mm aperture. It's a very large lens, 8 mm optic size. So you push in the proline through the eyelets and see always that the knob is below, not above the IOL. And this is the cautery. I just open a few sutures and first insert the lens rather than do it open sky, because this helps to maintain the IOP, reduces the risk of expulsive hemorrhage, which in an open sky technique is more common. So just open it and then put the IOL after the preparation. And once the IOL is in, then you can pull on the threads and you can see that it centers well. You cut it about 3 millimeters away and then you make a flange, and then you can bury the flange under the conjunctiva. And following this, you can see that the artificial pupil is there. Then the keratoplasty is performed, the regrafting is performed. This is done by a corneal surgeon. You put in the graft, and then this was the post-op day 1 pictures. You can see the, on retroillumination, you can see the pupil, artificial pupil, and the aniridia lens. This patient had about 636 vision on day 1. This was another very interesting case. This is a 14-year-old female with Marfan syndrome and came with a severe subluxation, ectopia lentis. This was a pre-op scan. You can see that she has got about nearly 2.5 diopters of astigmatism. Now in a Marfan syndrome, I prefer to remove the bag, because even if you put a CTR and then put in an Ahmed segment, it is a progressive condition, and after a few years you will have dislocation of the whole capsular bag and IOL complex, and you have to manage that again. So I like to do a scleral fixation. But now she has cylinder. How do you manage it? I have made my own lens, which is the swivel haptic IOL. So I decided to use the toric version of it. The swivel haptic toric IOL is extremely stable because you're fixing it to the capsulotomy. But here we'll see whether we can use it in a case of aphakia once we remove the capsular bag. This was the surgery. So that's the axis of placement of the IOL. So I put in a infusion port, and then you can see the zonules there, weak zonules there. I do a capsulorhexis. Now to remove this, either you can do a lensectomy, but I go in and do a capsulorhexis. After doing the capsulorhexis, hydro evacuate the lens. I put in a capsular hook to support the bag, and then go in with the IA and then evacuate it. And then with a micro forceps, I just peel off the bag. It's quite easy to remove. So just remove the bag, and then you have aphakia. Do an anterior vitrectomy, And this is my swivel haptic IOL. So you have the swivel haptics there, and at the edge of the haptic you have a small hole. So I put it through a regular injector, and it goes through a 2.8 mm incision, put it into the anterior chamber there, and then you can align it. You can see this is the axis. I align it, and then after that I open the swivels and then put in a Prolene through from above below, bring it out, and use a hot heat cautery to kind of flange it and then pull it. And then the same thing on the other side. Pull it below the iris and then put it through the hole, flange it, and you can see that it is, once it's done, you push the IOL behind the iris. Pupil is constricted now, but it is on axis. In fact, it's perfectly on axis and it will not move. This patient had 6 parts uncorrected vision. You can see this. You can see the edge there, which is parallel to the lines. And this patient is doing very well with 6 uncorrected vision. So you have a toric IOL for a scleral fixation through a 2.8 mm incision now. Coming to our experience with the modified 4-flange technique, retrospectively we looked at 52 eyes of 52 patients, and these were the indications: introp PCR, Marfan syndrome, introp ZD, subluxated IOL, trauma, dislocated IOL. And this is the visual and refractive outcomes. You can see that the pre-op best corrected vision was 618, but post-op it actually improved to 6/9 parts. Sphere pre-op was 3.33 because many of them were high myopes, and post-op it's 0.28 sphere. Cylinder kind of remained the same because we are not correcting it. The toric one is just an example which I showed. These were PMMA lenses, and this is the spherical equivalent minus 1.08, mainly because of the astigmatism. This was the IOP, which remained fairly stable, no secondary glaucoma. Some of the clinical pictures pre and post-op when we use a modified 4-flange technique. And this is the UBM. You can see that it's almost like a PCIOL in the bag, away from the iris. Introp complications, we had one with haptic slippage, one with introp IOL tilt, and one haptic breakage. But otherwise, most of the patients, 49 out of the 52, did very well. There were no introp complications. Post-op, we had one flange exposure, two IOL tilts, and 2 cases of hypotony. But most of the others did well. So the modified 4-flange technique of scleral fixation IOL is safe and effective, relatively easy to perform even for beginners. My residents also do it. Useful in hazy corneas, even if you're not able to visualize well, because most of the procedure is done outside, and it's got a short learning curve. Thank you very much for your attention.
Thank you very much, Sri Ganesh. It's a really excellent presentation. And the next person is going to be Keiki's son, Cyrus. And as everyone knows, Cyrus is again another great surgeon, and he's going to talk on his technique. A new technique of suturing a subluxated lens to the sclera.
Hi everyone, good afternoon. Nice to see so many people here at 4:30 in the evening. So basically, I'm just going to give a quick talk on subluxated lenses and loose zonules, including the video that Dr. Agarwal was speaking about. Let's go to the next one. So in a subluxated lens, should we use a ring segment or an ASIA anchor? And which one is indicated and how? So let's have a look at this.
Should we use capsule hooks or simply drop anchor when required in the case of a subluxed lens?
Can you put the volume off, please?
We use a femtocataract system to provide a perfect
So
4
basically
mm
in this
capsular
case,
rhexis.
we use a femto laser. If you want to create a perfect punched out rhexis, Even though
This
you may be
gives
very,
us
very skilled now
a
and then it
perfect
won't work.
punched
I'll show
out
you in the
rexus.
video. But with the femto laser, you always get
Next
a
we
perfect
use sodium
rexus. You just
hyaluronate to
a little
create
bit of
space for us between the
with this
capsular
square
fornix
elastic
anterior rim of the bag and the
engage the
cortex
capsule
it
with
holds.
capsule hooks.
Then we can use
integral to the
capsular hooks
success of a
which differ
procedure
from
like this, if
traditional
you want to
iris
keep
hooks
the
in
capsular
having
bag,
smooth
is
paddles
that
at their
you
ends
have
to
to
spread
have a
the
good
forces
capsular
applied.
axis. If you have a bad capsular axis, you cannot do this surgery.
After doing an
And,
INA,
if your capsular axis is
we
iffy,
then pass one
or
needle
it
of a
goes to the
double-arm
periphery, you don't have enough
ninoproline through a
removed capsule
capsular
to
ring
hold
segment.
the
Railroad
ring
this
segment.
needle out of the eye and then railroad the
So this is
second
actually
needle
not a
3
MR
millimeters
segment,
away
it's
from
made
the
in
first
India,
one,
it's called a Gupta
making sure
segment.
not to nick
It
the
does the same
capsule.
job.
Position this
Railroad a
ring
suture
segment
out of the
after
eye after
railroading the
suturing
second
it to
suture in the eye.
suturing whole of the segment.
Tension the ring
into
segment by suturing the
capsular
two
bag.
ends and follow it
Add a
up
CTR.
with a 12
And
millimeter
then inject
capsular
the ring.
tension
So
ring to
this is very
stabilize
simple
the
and
bag in its
straightforward procedure.
entirety
It looks very complicated,
and
but
then
actually
inject
it
the
isn't.
lens.
Now what happens? It
What do we
becomes
do if you have a
complicated
poor
if you
axis with a
axis,
small
a
rim of
small
capsule?
What option do you have in that case? One, you can just pull the capsular bag out.
Here
and
we
then
can
use
see an aborted
Ganesha's
rexus
dumbbell
with a
technique,
femto
which I
laser
do
creating
regularly.
disruption under the capsule
Now,
rather
in
than
this
at the
case,
capsular
femto laser
plane.
actually malfunctioned and didn't
Now it's
create a
time for us
capsular
to make a
rexus. It
good
looks like
rexus. Use
but
a sharp
actually it's
rexus
just
forceps.
perforations in superficial
But in this
cortex.
case, the rexus tries to run away.
So for those of us
Even
who
though
have
we
seen
can
Top
pull
Gun
it back,
Maverick, which is just released,
the capsular rim
it's
left
not the
behind
plane,
isn't
it's
good
the
enough for a
manual plane.
capsular hook.
So sometimes the machines do
So in this
malfunction.
case, what can we do now?
So the rexus
So let's
somehow
mark
got it
3
to run around,
millimeters from the limbus
but it's gone towards the equator. So there's
and then
not
let's
enough
look at the
rim
ASIA
of
anchor, a device fashioned after a boat hook
capsule to engage
with
capsule
two
hook.
limbs.
So in this case,
We
you need some
retrieve
kind
a
of a
double
device
arm
like this.
ninoproline from
So
supplies
this is
and thread
generation
one end
1
of the
ASIA
needle
anchor. It's got a
through the
generation 2,
suturing
which is 3
hole
dimensions like a paper
of the
plane.
ASIA anchor and then
This is the
tie
generation
tight.
1 anchor. So you can use the two
Railroad
trailing
the
legs
suture out of the
anchor
eye
to trap the
and
capsule
position the
and
anchor to
create a
support the capsular
And
bag.
just railroad it
After
out.
we can safely use irrigation and aspiration in a bimanual setup
And that's your
to
anchor,
then clear the
which
cortex.
taps the
So once we get this anchor
edge of
into
the
place,
capsule.
do a slow motion
eye,
irrigation
see that
aspiration
it falls
because we
inside
don't
the
want the anchor to dislodge itself from the
Once
capsular
that
ring,
is done,
which is
you
being
just
held
pull
by
on the
its
suture and create
two
a capsular
trailing
bag.
legs.
So now you've got a capsular bag good enough to put
Adjust the
in.
suture tension
I did go with a one-piece lens,
and then we have to lock the suture in place by
still in
passing this
place.
needle twice through half thickness of sclera.
But ideally, you should have used a
So
three-piece
that's
IOL
once,
for this particular
and that's
case. But I didn't
twice.
have one on hand. I
And
put
then
the
you
one
simply
piece and
tie
still-
tight.
it still
This
stays
gives you a
on.
good capsular bag
4
with
years since I
adequate
made the
tension,
video.
which will hold an
Let's
IOL.
go to the next one as soon as I pop in the lens.
Now it is time to inject the IOL gently. If you inject it ham-handedly, you might dislodge
Now that
the
you have a
anchor.
good capsular
So we
bag,
inject it slowly
you can
on top of
inject
an
the lens
iris
inside.
repositor and then dial it carefully into the bag.
So I wanted to show that suturing the bag to the lens, to the sclera, but that's been kind of done to that, and I presented that many times before. So I wanted to show you this interesting case that I did about 3 months ago. So I'm doing a scleral tunnel here. So if you notice, there's something very odd about this case. This is a PC lens which has been in the AC since 10 years. So a colleague broke the capsule and then implanted the 3-piece posterior chamber lens in the anterior chamber. And the lens sat there 4-5 years and didn't cause any trouble, but then eventually corneal decompensation intervened and the whole cornea is packed up. So now we have to explant it and then do the surgery. So I decided I didn't want to do too much jugglery, so I did a scleral-based tunnel, removed the IOL, did a vitrectomy with the AC maintainer, mark about 1.5 millimeters. And this is Sri Ganesh's dumbbell technique, which is very, very simple and easy to do. I used to just do the flanking technique, but then I found that the sutures would get extruded. So this is very doable, as you saw in Sri Ganesh's case when he opened the graft and put in the lens. These cases do well. So thank you for watching, and we'll meet rest of the conference.
Mahipal Singh Sachdev, and as you all know, he's been the past president of the All India Ophthalmic Society and also chairman scientific committee of the Indian Intraocular Implant and Refractive Society, chairman of Center for Sight. And Mahipal is going to talk to us on managing a subluxated lens with a femto.
Thank you very much, Amar. Thanks, Keiki, for having me in this course. Always a pleasure being with you. Well, I'll be talking about subluxated cataract, as my earlier speakers have said, that obviously it's a challenging situation which we have to take head on. The subluxated cataract, the aim in a subluxated cataract is to preserve the capsular bag. That is the most important thing, and try to center the capsular bag, which if it is decentered, for the lens to be sitting there. So this is something very, very important. If you have the capsule missing and you have vitreous coming out, the chances of retinal detachment increase. Now, the first and the foremost important thing is to do a clinical assessment and be prepared when you are dealing with a subluxated cataract. Normally, we would prefer to have a patient under a peribulbar block in these cases and to plan as to what we have to do. Obviously, when you are looking at a subluxation, you can see the signs, which is the pupil depth being irregular, phacodonosis, intralenticular space, and lens edge can be seen in the extreme gaze. So with a fully dilated pupil, you should go ahead and assess. Now, the reasons for the subluxation also need to be known, and depending upon that, you can actually see whether it will be a subluxation that could be progressive or it is something which is stationary, and accordingly it could make a difference as to what exactly you want to do in what situation. If you have a progressive subluxation and you're just putting an endocapsular ring, for example, a marfans or a homocystinuria, there could be a problem, and it could, therefore you have to alter your approach there. Now, when you are looking at the approach, it will depend on the extent of the subluxation that you have, and as I told you, on the etiology, whether it is progressive or not, and also on the grade of the cataract. If you are dealing with a rock hard cataract which is there and there is an extensive subluxation, it may be difficult to do a phacoemulsification. So typically when we have a subluxation which is less than 3 clock hours, that is less than 30 degrees, you put a CTR and you use, better to use a 3-piece lens, and the IOL haptics also act as a support and push back the subluxation which is there. 3 to 6 o'clock you could do a CTR, or you can do a ring fixation. So there, just putting a CTR is not going to help to that extent in some cases. So you have to do a fixation of the ring, or the technique that has been described by Amar of doing a glued IOL or a Yamana technique, etc. And if it is again, if it is more and it's a progressive disease, say even 3 to 6 o'clock, then you go ahead and do a glued IOL. And otherwise, if it is a large subluxation, we go ahead with the Yamanase or the glued IOL technique that is there. Now, the challenges that are faced is the creation of an intact capsular axis. So when you're doing a capsular axis with a needle or with a ultratas, the counter traction force is not there when you are having a subluxation, so that becomes a problem. There is excessive lens mobility, and there is a lens tilt which is there, and or displacement or in the presence of a vitreous. So that causes a problem in doing a capsular axis, makes it difficult. And in case you have a discontinuity in the capsular ring, then it becomes a contraindication for fitting a CTR, because then the it can go and extend posteriorly and get a total PCR that you have. So the other challenges that is there is that when you have a subluxation, there is an exposure of the vitreous. There could be zonular dialysis also at that time, and a vitreous is coming. So there is a continuous vitreous hydration that can happen during phacoemulsification, so that can enlarge the amount of subluxation that you have, and that can cause a bigger problem which is there. As also the hydration leads to an increase in the positive vitreous pressure. So that is something which is important. So how can we make this particular process easier? So I'm going to talk about 2 particular things. One is the use of a femtosecond, and the second is to use a pars plana approach to do a vitreous decompression which is there. This is thanks to Kumar. This is a patient with a small pupil, irregular shallow AC, angle closure glaucoma. PI has been done. Patient has tamsulosin, hard cataract, and let us see how it is handled with a femtolaser which is there. So you can see this is the cataract which is there, non-dilating. You can see the peripheral iridotomy that is there. Again, another view, irregular chamber, sphincter atrophy because of the uh, angle closure glaucoma attack which is there, and you can see here that this is irregular. You're trying to see the lens and see the phacodonosis in this particular case. So pre-operatively, you can see the movement of the lens. Can you appreciate the phacodonosis, which is clear in this particular case? So pre-operative assessment has been done. So in this particular case, there is you need a good exposure because the pupil is small. I'll just show you. This is a Malugin ring that has been placed. And can you see the bowing of the iris here and the bowing upward? So it clearly shows that there is a subluxation, there is an irregularity in the chamber. And you are, in this particular case, doing 4.9 rexes because the pupil is not that large, and you can go ahead. Now the femto in this particular case affords you a good capsular rexes because you are matching the anterior capsule onto the OCT image. So you will get a very good capsular access. The second thing that you will get would be a disassembly or a breaking of the nucleus. So therefore, the amount of energy or the manipulation that you are going to do is going to be much less. So you can see this is the laser that is taking place, and you are completing the procedure of making 6 quadrants. Now you can see that once these quadrants have been made, the patient is going to be shifted to the OR, and you can, the nucleus has been taken out, and we are using low parameters in this particular case because you don't want a turbulence. You can see the mobility of the nucleus which is there, and one would be needing to be very careful. You can see that the rotation is having a little difficulty because the hydrodelineation we have not done. And in this particular case, we trying to use 2 manipulators or 2 hooks to actually be able to rotate the nucleus. Then in addition, this is to support the capsule. A capsular hook may be a little better, but this is an iris hook that is being used because this is the place where there is the maximum mobility of the nucleus at that particular point. So you're putting a capsular hook, iris hook, and then you can see the procedure of phacoemulsification is started, and one is able to support this pretty well, and you can see that again the epinucleus is still left, and epinucleus was still left, and you see that there is mobility. So there is another iris hook that has been put out here. You can see this. This is the iris hook that has been and is working as a capsular support. So now you have a Malugin ring. You have 2 iris hooks. You could put in a capsular tension ring at this time, but normally it can take an issue of getting the cortex entangled and the epinucleus. So it depends at what stage you want to, but the dictum for a CTR is don't put it too early and don't put it too late. So that you have to see as to the clinical situation that you are in, where you want to put the ring. And you can see in this particular case that the epinucleus is being taken out. This is the cortex that is being taken out now. And once the cortex, you can see that the bag is pretty mobile in this particular case also. So once you have to be you need to take it out very cautiously. And then once again you can see these wrinkles on the capsule. So clearly it shows that there's a subluxation. So this is the time to go ahead and put the capsular tension ring to keep the whole thing in position. And you need to guide it into the capsular bag. So you are guiding the caps into the capsular bag, and herein we are putting in a single piece lens, and it is well centered. And then we will take out the Malugin ring and the iris hooks which have been used for a capsular support, and any vitreous that has come, that is being taken care of and done. So while this total approach was an anterior approach, now let's see that we are looking at a posterior approach in which we are doing a vitreous decompensation, and a valve trocar is placed at the pars plana site around the area of the zonular defect, which allows a limited dry vitrectomy that you are wanting to do, and with moderate cutting and low vacuum you can go ahead and do this. So this is a patient, a doctor from Patna, who came with a post-traumatic subluxation. As you can see, examination has been done. You can clearly see phacodonosis, nucleus grade 3. Plan is to do a femto-assisted in this post-traumatic subluxation. So I'll just show you, we're going ahead in this particular case. For those who have the catalyst or the femto system, you can try to center the capsulotomy on the pupil center. You can center it onto the to the capsular center, or you can customize it. So in this particular case, you are making the interior capsule on top, making it meet, and then you can see that scanned capsule is coming to the side and it is cutting the iris. So from a scanned capsule, we go on to a custom capsulotomy, and then you put it, and from 4.5 we are increasing to 4.9, and we go ahead and do the femto laser procedure. Once the femto is done, here what we are doing is we are doing a pars plana approach. You can see we are using a trocar cannula. You can see a big subluxation. So ideally this is a problem which you are going to expand if you are not using a vitreous decompensation. We have put tricort. Once we have put tricort, you can see that we are removing the vitreous. The traction goes down and the decompression happens, and you will not be hydrating. Now, despite the vitreous which was there in this particular case, we were able to get a good capsular access. You just need to be a little cautious. I am putting the ECR right in the beginning because there is a huge subluxation that is there, and I have pre-chopped the nucleus and it is not that hard. So you can see it is easy to section the pre-chopped nucleus. Go ahead without much manual rotation that you have, so you're not rotating it very firmly, and you can see that one is able to take out the nucleus and the epinucleus that comes out pretty easily. And then this is the IA that is happening. We are putting in a 3-piece lens in this particular case. Now going back, doing a vitrectomy again to decompress what is there, and you can see that there is a tag of vitreous which is coming in this particular area. We're trying to remove that, use a manipulator, and once you're using a manipulator, this is something that we are wanting to now go ahead, and now we switch the hands. We'll put the infusion posteriorly, and we will then go in from the front and do the removal of the vitreous tag that was there. So at the end of the day, we have a great outcome that is there. So I've showed you the use of femto laser, both from the anterior as also the posterior, working on both these with vitreous decompensation and taking care of subluxations which is there. This has been published in Limited Pars Plana Vitrectomy for Optimizing Surgical Outcomes in subluxated and femto assisted. So the advantages are that prevents vitreous herniation into the anterior chamber and limits extension of zonular compromise, deepens anterior chamber, creates adequate working space and relieves positive vitreous pressure, and allows safe phacoemulsification with appropriate capsular expansion and fixation devices and implantation of an intraocular lens. So these are two cases that I wanted to show you. Take home message: low fluid setting should be there to prevent surge of fluid into vitreous cavity, tamponade the area of zonular defect with dispersive OVD. Femto-assisted capsulotomy reduces the risk of further complications, and vitreous decompensation allows safe phacoemulsification. So difficult situations often use the best, often yield the best rewards, and I think femto is a good tool when you are working on subluxated cataracts. Thank you very much for your kind attention.
Thank you very much, Maipal. That really was a marvelous display. Our next speaker is Dr. Amar Agarwal, who's going, as you all know him very well, literally the king as far as phacoemulsification is concerned, and developing multiple new devices all over. And he is going to talk to us on the glued IOL and variations on it.
Thank you very much, first of all, Keiki, for inviting me for this lovely course of yours, which you conduct every year. So basically what I thought was show you first of all one nice case here. Now if you notice here, this was a case of a subluxated one piece non-foldable IOL, and notice also the patient has got a iris damage also with it. So question comes now, what do we do in case like this? The problem is, one, you can explant, but I was thinking if I explant this IOL, I might be in more trouble because of the cornea. So I'm going now vertical. If you notice, the horizontal is very wide. When you have a longer white to white, measure it. Anything more than 11, be careful. So always go for the shortest distance possible. In this case, I've gone vertical. When you go vertical, see, I made my flaps vertical. That means I have to now rotate the patient, because you should be sitting at 90 degrees from wherever the flaps are. That is called the correct shake for handshake. You need to do a handshake technique. Without handshake technique, I will not be able to fix this IOL. So I am sitting now at 90 degrees to my scleral flaps. I'm doing my vitrectomy, as you can see. Now you see I've done a 22 gauge sclerotomy under the scleral flap. Whenever you have a large eye, remember one thing, these IOLs are all 13 millimeters by and large. So make a small iridectomy in the area of the scleral flaps. Notice that. Watch, my assistant is holding an endometer for me to see better. Why am I doing that? I can come more anteriorly. So I'm going to be at 0.5 to 1 millimeter from the limbus. Normally people go 2.5 millimeters. Don't go far back. If you go far back, the simple point will be the amount of haptic externalized will be less. So the amount of tuck will be less. So I made a small iridectomy there. So when I do that, see how anterior I am. And I'm going through the iridectomy. So the advantage here is the iris does not get damaged. So far, so good. The problem in this case is it's a single piece, non-foldable IOL. These are very tricky to externalize, because if you manipulate a bit extra, they will break. On top of that, notice this haptic is entangled to the iris. So now you have a second problem is I have to remove that entanglement. As you can see, I'm trying to remove it slowly and steadily with my two hands, but invariably you notice the iris is getting damaged with it. It was already damaged before. With this, it becomes even more damaged when I'm trying to remove the entanglement. Now watch, I've caught the tip of the haptic. If this is a 3-piece, even if you don't catch the little tip a little bit, you're okay. But when you are doing this game with a single piece, non-foldable IOL, I am very clear I have to catch the tip, and it should be the same axis I'm catching it as I'm pulling it out. And you can see the haptic out. So far, so good. One haptic out, game not over still, because I still have to clear my second haptic. Now, we have to be very careful, as I said, to externalize the second haptic, because this lens can still break. But if it breaks, all I'll do is explant it, and I'll shift back to a 3-piece IOL. Now you can see I've rotated the lens a little bit so that my visualization for the second haptic comes into play. Here you can see I'm doing a little bit more of vitrectomy because I don't want any mess around that area there. Once I have done that, now I'm going to catch the haptic. Now see, this is the handshake technique I was talking about. I am using 2 forceps. They are like your hand. But my game plan is simple. I need to catch the tip of the haptic and externalize it. So here you can see, till I catch that tip, I am not going to pull out. Once I have caught that tip, I pulled out, and luckily the haptic has not broken. So far, so good. Now look, next step, do some vitrectomy around it. Notice carefully, it was a large eye, but the amount of haptic externalizes a lot. So obviously, if I now tuck this haptic inside, I'll be safe. Here you can see now, when you are tucking a 3-piece, you can just flex and tuck, no problem. When you are tucking a single piece non-foldable, you cannot flex, it will break. So withdraw like this and then tuck it in. So see, I'm withdrawing it back into the sclerotomy area, then pushing it into the opening of the Gabor Chariot's pocket. So here again you see I'm going back in, then when I find my opening, then I will tuck. Now where is the disadvantages and advantages you see of glued and Yamane? The Yamane, it's picked up so beautifully because it's so simple and easy. The reason why I'm sticking to glued eyelids, one is obviously this case is a non-foldable, so you can't do Yamane in this. But the second reason why we are sticking to the glued is because of the tilt. In the glued, I can tuck, untuck as much as I want, so the amount of haptic will be like that and the lens will get fixed. And the amount of tilt will be absolutely negligible. Now look at that. There'll be nearly no tilt. We did a study on that, and a 5-year study which was published in the Ophthalmology Journal, which is the premier journal in ophthalmology, the American Academy Journal. And we found after 5 years, and I'm talking my early cases of glued eye, we got a 2-degree tilt on anterior segment OCT. If I put a lens in the bag, you'll get about 1.5 degree tilt easily. Okay, in the bag I'm saying. If you put in the sulcus without a capsule being present, only rexus being present, you'll get a 5-degree tilt. So that's when big advantage of the glued eye works, where you have a just 2-degree tilt. Case not over. Remember, 1, I damaged the iris. 2, the previous iris was also damaged. So I have to now suture back that area inside. So how do I do this? See, I've taken a straight Prolene needle, gone through clear cornea, gone through iris. Now, catch on the other side, you can see here. Now through a paracentesis. Remember, I need a paracentesis only on one side, not on both sides. Take a 26 or a 30 gauge needle, pass it through the iris. Here you can see I'm passing it through the iris. Now, railroad the two. Now, once I have railroaded the two, the iris suture comes out. Simple. So, it comes out through the paracentesis. Fair enough? Now, all I need to do is bring the single loop out. So, this is called the single pass. And pull that single pass loop out of the paracentesis. Now, remember the number 4. So, you just pass it 4 times. So, that's why it's called single pass, 4th row pupiloplasty. And I'm doing it 4 times. Once I've done it, pull on either ends, and you see the pupiloplasty is started and the iris repair being done. You can do it as many times as you want, in any location you want, wherever you're comfortable in, because the procedure is so simple. Anyone can do it. Normally, what we do a 3-2-2 or something like that, whatever it is. In this, it's just a single time, once, 4 throws, and that's game, set, and match. Now I'm doing in another area. See, wherever you want, you can do, as I said, because the procedure is simple, but my idea is simple. I got to make that pupil smaller. Now watch my Purkinje image. Look at P1. The P1, which is the central one, should be centered on the pupil. That's important. If it is not, the results will not come as efficiently as you want it to do. So here you can see my Purkinje image. You can see that triangle there. Look at the inverted triangle, just for your information. If you see an inverted triangle on the, here I'll just show it to you. This is the P1. This one is P4. Okay. The larger one here is P3. Okay. P2 you don't see. So this is P1. This is P3, which we don't need. And this is P4, which is the inverted image. Again, we don't know. Concentrate on the central one, which is P1. And see, that's bang centered onto the pupil. Put in triamcinolone just to see if is there any vitreous, though I know I've done vitrectomy, but just to check there's nothing in the anterior chamber. And you can see I've cleared up this whole area there, put in some air, and now you can apply the glue, seal everything down, and you'll see how the case looks now when it's completed. 2 weeks post-op, you can see the vision has already improved to 6/9, and you can see the preoperative and the post-operative picture. So thank you very much, Keiki, for asking me to present on this case. I want to once again thank Keiki for his lovely course and ask, who's speaking next? Suhas? So Suhas Haldipurkar is the next speaker here. And as you know about Suhas, perhaps one of the best human beings and a surgeon combination is very rare to get. But one more thing before I bring in Suhas on this table, I'll tell you one thing about him is, when I was, I don't remember, I think it was in the United States, I met someone, and Suhas is invited every year to Europe to teach people, phacoemulsification and things like that. And that's just fantastic. And he goes traveling all the time there, giving it. He's always there in Chennai for our July conferences also. But I tell you what, I don't think there's a better surgeon than Suhas today. Fantastic. Suhas.
Amar, you have been always extremely kind and generous. In fact, in this course, we have seen some fantastic films. And after that, for me to come and speak on very basics, even I feel very conscious, but the topic is such that it's a post-traumatic bag lens complex hanging. So, yeah. As you get senior into your practice, to get lens drop or to get lens bag complex drop has become very common for the simple reason is that once your operated patients, like now today lens has been there in this, we've been doing it for more than 25, 30 years. So most of the lenses after 15 years, if the zonules are not strong enough, sometimes you do get. But today we are going to speak about the lens bag complex dislocation. And there are several reasons for that. And trauma also happens to be one of the very common reasons. In many cases, even if you don't see a straight history of trauma, if you go into it, you'll always find that there's been a micro trauma all the time happening because there are some chronic rubbers. They keep rubbing their eyes and they do get. In traumatic dislocation, the blunt force, we know how it really works, and you have a backward thrust and recoil. And finally, there's vitreous, which forcibly recoils around the lens. Now, this is a very interesting case. This patient came to me 12 years back. He was a child. He was 13 years old, and a trauma caused him, trauma caused traumatic hyphema, and the entire crystalline lens subluxated into his anterior chamber. I operated him, and at that time, I put a Sionis ring. And 2 years back, he comes back with another trauma, and again the lens bag complex comes into the anterior chamber. And what has happened is that trauma has caused rupture to his suture that I had put, and obviously I had put 10-0 at that time. And even if I had put 9-0, it would still be because there was a clear-cut history. So I had different ways of doing, either get the whole thing out or fix the same. And to my luck, I decided to put a 9-0 through it and thread it through that central eyelet, and somehow it worked. And what I do here is I make a groove, and through the groove I get the suture in, thread it through that central eyelet, and there was another thing. When the original trauma occurred, he had traumatic mydriasis, but at that time, Amar's fourth rows, single throw, fourth row, phobos wasn't there, so I couldn't really do his pupilloplasty. But at this time, I had an opportunity to complete it, and I did it, and surprisingly, his vision post-op did improve, and he was doing good. Now, this is another patient. He came with a very simple blunt trauma while holding his child. And he said, I was just holding, and suddenly, it hit me, and after that, my vision was blurred. This is the third day the patient comes to me. And what has happened is, this is an old, cataract surgery where even the rhexis is not very intact, and there are irregular fibrosis. So I decided to fix the haptic. And for that, I made a scleral tunnel at the axis of where you can fix the thing. And there was a lot of peripheral fibrosis, so I wasn't really worried that if I take my thread, suture through the haptic, it would tear through, because the capsular bag that was covering it was all fibrous. First, I had to ensure that there was not much of adhesions, and once I knew that the haptic can be pushed back easily, that's when I go with the needle under the haptic and take it out by railroad through a side port. And on the repeat, take the same suture above the haptic. And once you tie it, the lens comes back into its position, and the vision is regained with a very simple technique like this. Then there was another patient who also who didn't give a clear-cut history of trauma, but on close examination, I realized that he was a chronic eye rubber. He used to rub his eye all the time. And one day, after he rubbed his eye for his itching, he suddenly noticed a blur in his vision. In this case, the rhexis was intact. And first, I decided to check if I could go, because if the eye, cataract surgery is long-standing, sometimes it is difficult to get under the rhexis rim. And this was 3-year-old surgery. Once I was sure that, I could get in, with viscoelastic pushed in under the rhexis rim, I tried to inflate the bag. And after that, first I had to fix it with 2 sutures. And in this case, I decided to use ASIA anchor for fixing this. ASIA anchor, I had a choice of using either Ahmed segment or one of the modified segments or anchor. Anchor is my favorite for the simple reason that it's like a paper clip and it's in one plane. So when you fix it and then it's pulled and sutured, because it is in one plane, for the pupil to slide over it, it's very easy. Unlike in a Ahmed segment, it's very difficult sometimes for the pupil to really close on the segment, because the central eyelet is all the time seen in the pupil. Whereas once you fix it, this clip goes into the periphery so well that one thing, it is not seen. Number 2, the pupil glides over it, without any discomfort. And the other thing was, you only need to enlarge this opening to around 2.5, unlike Ahmed segment where you have to enlarge it to around 2.8. And the trick here is that you have to use the micro forceps to hold this, because to get this ASIA anchor, across the rhexis rim is little tricky. But the forceps does a wonderful job. You pull the sutures, fix the bag, and after that only you can take your hooks out, because without the hooks in and without the amount of little tautness on the bag, it is difficult to fix an ASIA anchor. And once you have sutured it, you naturally evacuate the viscoelastic and then constrict the pupil. This pupil wasn't really constricting well much, but then it wasn't my real concern, because the lens bag was firmly fixed, and the visual recovery was good. And here you can use glue to just close that scleral flap and conjunctiva over it. So these were 3 cases I thought I would share with you. Dr. Keiki Mehta, sir, I would like to really thank you for this opportunity every time you give me to show some of my cases. Thank you so much.
Thank you very much, Subhash, for coming. As you are aware, now you are aware how wonderful a surgeon he is. Fixing an ASIA anchor is really an extremely difficult task, and in its hands it looks simplicity. Thank you very much, Subhash. Our next speaker, our last speaker, the best one, is Dr. Kumar. He's a new and budding surgeon in Bombay. Well, new means what? 10 years, 15 years, Kumar? 25 years. And he's been doing work which is more and more exceptional every year. He's won a number of videos internationally and in India, and we look forward to hearing him.
So I'll quickly, I know we all are getting late, and I'll show 3 interesting cases. So I'm just going to show you what I do. With the COVID thing going on, everyone wants to have new targets every year. So this is a very interesting case. Some of you might not have seen this lens. So this is how the patient presented to me, 1. And 2, this is all the pupil dilates. So it doesn't dilate more than this. Now you can see that the lens is subluxated. Some of you might not have seen this lens at all. So this lens is a big lens. It's a 6.5 millimeter optic. It's got dialing holes. So in olden times, Dr. Keiki would be knowing about this lens. Those dialing holes were used for dialing the lens into place. So it's a single piece, three-piece, non-foldable, large IOL with a 14 millimeter overall range. So now this, as I told you, this is all that the pupil dilates. What to do next, because the lens is decentered. So of course I did a port. I made my, because I want to do something, either I remove this lens and put another lens, depending on what I want to do. So here I decided to make two flaps for gluing in the future, whatever I decide. Once that is done, now the pupil is a big issue because you really can't see much here. And visibility is not there. You can't use a Melugan ring or a Bhattacharya ring. You have to use hooks because you need more visibility. So here I go ahead and put 4 hooks. As you can see, I put 4 hooks. And then, of course, there is vitreous all around. You do your vitrectomy. So you can see a large lens sitting there. Do your vitrectomy, remove all the vitreous, and then center this lens. Once the lens is centered, you bring the same lens out. And you can see it's a large haptic too. So it's not a modified J, it's like a C haptic, which is a huge haptic. Now go ahead and bring one haptic out and do the same thing. Do your vitrectomy, do the other port on the other side, bring the other haptic in the anterior chamber, then do a handshake technique. And this handshake is little more difficult because the haptic is large in size. So it's not as easy as a modified J. Like a sensor IOL haptic is much easier than this haptic. So once you've done your vitrectomy, clear the vitreous all over, go ahead and do your handshake technique and then bring this haptic out and then go ahead. So here you can see this is the handshake technique. I'm holding the tip, bringing it out, and go on the other side, again holding the tip and bringing it out. Once you've done that, you can release all your haptics, the iris hooks which you put, that because that gave me adequate exposure. That was enough for that moment. And now this is the other handshake technique, and bring that haptic out. So now this is the same IOL. So all the calculation issues, everything is sorted. You don't need to worry. And once you tuck the haptic inside, you put your glue, remove all the iris hooks, and then constrict the pupil, and this ends this surgery. So I have recentered the same decentered IOL. So this way this works very, very well. So sometimes you have to fish IOLs. Now some of you might not have seen this IOL. Patient was operated by me 14 years back. It's called a bifocal IOL, 733 and 737. And this is how the patient came to me. So many times we go ahead and do a YAG. It's very important that any multifocal IOL comes to you with YAG. Please don't directly do a YAG with dilating. So somebody will dilate and you go ahead and do the YAG. Never do that. Always see the patient undilated. Sometimes you'll see that a multifocal IOL is decentered. Then what are you going to do? So here I'm going ahead, and this is how the dilate in a patient is allergic to Tropicacil Plus. So all I needed to use was Cyclogic. Now when I use Cyclogic, this is what I saw. So you see a YAG opening, a multifocal IOL, which is somewhere in the bag or somewhere sitting. And now the next question is, patient wants multifocality. Now what are we going to do here? So under topical anesthesia, the first step, of course, we put epitrate and we dilate the pupil, right? Now the pupil dilates. So you can see one haptic. This is an auto dislocation. A haptic separates from the optic. I have seen 2 or 3 cases of my own. This is a very, very old. It was made by Adtech. Now this company is bought by Zeiss. No longer they are made anymore, but this was a bifocal IOL. So you can see that now I'm going ahead and putting tricot, going ahead and doing my vitrectomy, because that was a YAG capsulotomy done right in the center. And now you can see the disc rotating around, okay? So now you go ahead and need to remove this, and don't forget, patient wants multifocality. So now explanting this disc is question number 1. So we make the incision about 3 millimeter, use a microforceps, use micro scissors. You really don't need to cut through and through. Many times they show you videos of cutting the optic through and through. You really don't need to do that. You use your incision itself as a fulcrum. So you need to cut only till the half, and now I'm engaging and pulling, and then I'm rotating the optic around the incision itself. So the optic itself is rotated out, and the cut of the optic is used as a fulcrum in the incision. So this is how the whole optic is got out. Now don't forget, you still have 2 haptics inside. Now one haptic is in the bag complex. I'm not worried about it. It's inert. Don't worry about it. Forget about it. But one haptic is in the sulcus. So I'm going to remove that haptic, and you can see the YAG opening. So because the rest of it is a fused bag, okay? All around it's anterior posterior capsule fused. I'm going again with the microforceps. This was a dislodged haptic which now I'm removing. And now the question is, the patient wanted multifocality. Don't forget that. Now, what are our options? So here I go ahead and do a little bit of more vitrectomy. Then I take over a Sensor 3-piece multifocal IOL. Once we take that, we load it and put it in the sulcus. And now I'm going to put that in the sulcus, and then I'm going to do a optic capture in the YAG opening. Okay? Now this will never ever decenter. So we don't need to really worry about that. Go ahead and now put the lens in the bag, in the sulcus. Once I've done that, so you can see that the inferior optic has slid below the bag complex, and the superior optic is also above the below the bag complex. So you can see this whole bag complex and this whole bag complex is actually, and the whole optic is beautifully captured in the YAG opening itself. Now the patient comes to me, that this is the last case, I won't take more time, like this. So patient gave a very peculiar history. When I lie down at home in night, I can see well. But when I sit up, I can't see. Okay? So you can see this. Now don't think that this is a haptic itself. Now let's dilate this patient and see this is how it is. So the whole bag complex has got dislocated. But there is an endocapsular ring with the haptic. Don't forget, it's not only this. So the whole back complex with the endocapsular ring has got dislocated. Now the question is, what are our options? Position the haptic of the IOL, you can note the CCC margins. Options is either to explant the whole complex, or you glue IOL and remove it and do an iris claw, or what else can we do? So we have 2-3 options here. Either I remove the whole complex. If you remove the whole complex, you do a glued IOL or you do an iris claw. So this is a pre-op video. You can see that there is a donesis. You can see the haptic margin. You can see the endocapsular ring, and the whole complex is moving. So we went ahead and did the surgery. I decided to refit this back complex. And how are we going to do that? Of course, you need support from the back. So I decided first, why not prepare for the glue in case something happens and we have to remove it. We might have to do that, nothing to worry, but let us prepare for the worst scenario. Here I've just made a Hoffman's pocket going ahead. And now if you look at it, the whole bag looks quite central. So it doesn't appear decentered or dislocated. Now here I'm doing a railroad technique. The first one goes above. So you are going above the back complex. And once you've gone through the back, above the back complex, then you go with the other side and then come out. So this is a simple railroad technique, but you have to get the same spot. What I mean is, if this is your haptic, you have to get the same spot on the opposite side of the haptic. You can't have one haptic here locked in and the other haptic somewhere else locked in. So this is one railroad technique. Now I'm going ahead and doing the second part of it. And that will go below the bag, and that means I'm holding the haptic and the endocapsular ring together. Okay, so there are two things happening here. So one was below and one was above. So I'm going ahead and coming out this way, and now I got one side fixed. Now let's go on the other side. So you do the same thing, you do a railroad technique. Now don't forget, as I said, this spot of the endocapsular ring and the haptic should be almost the same on both sides, because that will actually center the IOL well. So you can see that the endocapsular ring and the haptic is above my needle, and the second pass that I will do will be above and not through and through. So the first needle went through the bag. I was holding the endocapsular ring and this, and the other one is above the bag and then coming out. So now I've got the loop coming out on both sides, and then we just pull these two threads and then tighten it adequately, and that will center the bag perfectly well in the center. So you can see now the bag is very, very well centered and it goes fine. So this is the end of it, and you can just glue the rest of it. You really don't need to take any more sutures. So this was refitting a dislocated endocapsular ring with a bag complex. So this is the first day post-op, and the patient did very well. So take-home messages: listen to the patient, rethink what are the options, and you can use any one of these options. So sometimes this can happen if it is bad luck, and you may be lucky, and this can also happen. So you have to be careful, you have to think different, and that works quite well. Thank you for your attention.
Thank you very much, Kumar. That really was a marvelous bit of work. I mean, it shows what an exemplary surgeon you are. Congratulations. And thank you all for coming. I hope you all enjoyed this this group of really unique videos. And now I leave you all to enjoy and see Aishwarya downstairs.